Good afternoon, friends. Welcome back to my channel, Pediatric Classes. Hope you are all doing fine. It's a while since I've uploaded a video. I got a little busy with some other commitments. So let us now discuss today an important topic, that is the supraventricular tachycardias in children. So I would like to use the reference by the IAP. This is the standard treatment guidelines from IAP. So let me start sharing my screen now. Okay, so before the start, I would like to thank the lead author, Dr. Amitabh Chidapadhyay, Dr. co-authors, Dr. Vikram Dumala, Dr. R.S.K.S. Ramadevi, our National President, Dr. Ramesh sir, our Honorable Secretary General, Dr. Saxena sir, and all the faculties actually who have come out with such a beautiful guidelines on supraventricular tachycardia. So let me go straight into the topic. So what is meant by SVT? So this is SVT is supraventricular tachycardia. So what happens there is an abnormally rapid rhythm. In infants, if you see, the heart rate is more than 220 per minute, and in children it comes generally more than 180 per minute. This will originate proximal to the bifurcation of bundle of His and is caused by an abnormal mechanism, specifically excluding the sinus tachycardias. Okay. If you want to know about the exact pathophysiology of how the conductive system in the heart, you can refer back to my previous video on ECG made easy part 1. So the general characteristics are SVT is the most common sustained arrhythmia in children associated with a structural heart disease in around 20% of children. What is the speciality about this SVT? It is characterized by a narrow QRS complex. When I say narrow QRS complex, it is 2 boxes, less than 0.09 seconds. There are exceptions, like wide complex can exist due to coexisting bundle branch block or antidromic re-entry tachycardia, which should be treated as ventricular tachycardia unless proved otherwise. So for all practical purposes, we should know that it is a narrow complex QRS is there in case of SVTs. So there are actually 2 mechanisms. One is like re-entry. Other thing is abnormal automaticity. Re-entry is the most common cause. That means the path it is coming, the conductive system is coming, actually the pulses are getting reconducted. That's called re-entry. That is found in 90% of the cases, like in atrioventricular re-entry tachycardia, AVRT, atrioventricular nodal re-entry tachycardia, when they re-enter the AV node, that is AVNRT. This is the most common thing. Okay, please note here, AVNRT is the most common cause of SVT in children. This is for my NEET aspirants. Sometimes they may ask you what is the most common cause of SVT in children. This is the answer, AVNRT. So ectopic atrial tachycardias, EAT, junctional ectopic tachycardias, JET, and permanent junctional reciprocating tachycardias. So when I say the mechanism, this is under the diagram which is given in that standard treatment guidelines from IEP. So the mechanism is, one is re-entry, that is excitation wavefront travels along a circuit to return and reactivate the same tissue from where it started. So this is the thing, AVRT, AVNRT, atrial fibrillation, PGRT, etc. Whereas automaticity is the cause. That means an abnormal focus is there that spontaneously fires, and that causes the abnormal heart rate in cases of EAT, that is ectopic atrial tachycardia, and JET, junctional ectopic tachycardias. So please understand there are 2 mechanisms. One is a re-entry, another thing is an automaticity. So most of the children may present with stable hemodynamics, but that presentations may vary. That is right from asymptomatic to cardiogenic shock. That is there's a wide spectrum. So that presentation actually depends on the age, the duration of arrhythmia, and the pre-existing cardiac status. In case of infants, they may present with acute heart failure because this tachycardia will go unrecognized for many hours. The child will be just irritable, child may have pallor, tachypnea, poor feeding, etc., which we may attribute to so many other causes. So if you see a baby with all these features and a very high cardiac rate, heart rate, be aware, have the diagnosis of SVT back on mind. Another thing is, we always consider the diagnosis when the heart rate is really high. Okay, in the older children, they may present with history of rapid regular palpitations, which may be paroxysmal. Here, they don't generally land up in heart failure because they are big children. They will go and talk with the parents and tell, Madam, I am feeling fast heart beating or beating heart, something they will tell, or the parents may notice it and they may bring the child for checkup. So generally infants come to us with acute heart failure in case of SVT, but as older children, they may just come out with the paroxysmal tachycardias. Another thing is a case of when we may see is a subacute or chronic heart failure with failure to thrive. This case comes in case of incessant tachycardias like EAT and permanent junctional reciprocating tachycardias. So I have a question out here for NEET aspirants. Please note this. They may ask subacute or chronic heart failure with failure to thrive. So don't miss these things, EH and PGRDs. Sudden cardiac death may be a rare presentation of WBW, that is about Parkinson's White syndrome with AF due to conduction of a rapid rhythm to the ventricle causing a ventricular fibrillation. So the spectrum is very much varying. So whatever when you treat your child with tachycardia, please don't forget to take 12-lead ECGs. And once the diagnosis is established after posterior sinus rhythm also, you have to repeat an ECG. Please note that. So what will you see on a 12-lead ECG? You have to find out the range, the rhythm, the narrow versus wide. You have to find out whether the QRS is narrow or wide. So please note there's a small correction here. Narrow QRS is less than 0.08 milliseconds. Okay, that is 2 boxes. One box is 0.04 milliseconds. For any clarifications regarding the reading of ECG and all, you can refer back to my ECG videos, that is ECG made easy part 1 and part 2, where we have actually discussed in details regarding all these things. Now, coming to short RP versus long RP. So this we need to know. What is short? Generally, we hear PR interval analysis. That is the interval between P and R. So this is like from the QRS wave, from the R, where is the P? So that depends the RP. Okay, so how will we know it? So here the others are recommended, like what we can do is we can draw a line between the two QRS complex and see, like I'll show you a diagram. So here like this, if you draw a line between the two QRS complex, and if this P is coming before the line, take it as a short RP, and if this P is coming after the line, take it as a big RP or a long RP. I hope it is clear. Yes, if I am using a line, drawing a line here, and this P is coming before the line, no? So that is a short RP, and if this P is coming beyond the line, that is a long RP. Okay. Okay, now next. Now, what are the clinical clues? You know, there's sinus tachycardia can also present with an abnormal heart rate, but then generally they will be having a history consistent with the known causes like fever, sepsis, dehydration, etc. And they may also have ECG features. When you see, the rate will never be more than 230, generally less than 230 with varying rate. But please remember that P-axis will be normal. This is also a case of long RP with the short PR. Okay, adenosine response transient AV block, okay, and needs treatment for the cause. So this will have to, we have to treat the cause for get the things corrected. Now coming to AV, don't get confused with so many things, but you just have to know, okay, these are the main common causes of supraventricular tachycardia in children. Actually, how to differentiate between AVRT, AVNRT, and other things actually are a little beyond the scope of the session, but still because the authors have given a very beautiful slides, I thought I'll include that also. So even if you are not like really into it, nothing to worry. So AVNRT also please understand, this is adenosine response I want to tell, and the ECG features, and also clinical clues. Clinical clues I already mentioned. Infants will come with heart failure and palpitations in older children. When you see the ECG features, it will be really rapid. That is like 240 plus in children. But retrograde P will be embedded in the STT segments. Again, this is a case of short RP. Okay, so why I told this in so many places it is mentioned short RP and long RP and all. See this previous slide. If you see sinus tachy, there's a long RP, whereas in an AVRT, it is a short RP. Adenosine response, definitely it will get terminated, and is the most common type of SVT. So AVNRT is also the most common type of. Now see this diagram. So this is see this narrow QRS complex very evident, but the rate is around 250. How will you get the rate of 250? Again, refer back to our previous videos, but still I'll tell you, it is 1500 divided by number of small boxes. So if you actually see 1500 divided by, when I see this, when you count the small boxes, I'll tell you this one. So there are around 6 small boxes in between. So this 1500 divided by 6, that is 250. And ST segment is distorted because of the retrograde P wave. And AVNRP is also there. This is rare before the age of 2 years and increases in frequency in childhood and adolescence. So here again, narrow complex, QRS complex tachycardia with P waves visible as a discrete deflection in the terminal part of QRS. This is also very terminated by adenosine. Okay. Atrial flutter. So what is the problem with atrial? The rate will be really high. That is around 300 to 600 range. So there I told you it will be around 200 to 40, maximum 280, as far as that range. But in atrial flutter, really has a higher range. Even if you give adenosine, what happens is a transient AV block, but this flutter waves will be there, which we can appreciate when the AV block also sets in. This causes, main thing is atrial fibrillary flutter is one of the major causes of fetal tachycardias. The response to DC cardioversion recurrence is uncommon. See the flutter waves? So many flutter waves. Can you make out one other thing? Where is my point? Huh? See here, there is a 4:1 conduction. If you can make out here, there is 1, 2, 3, 4, and 1. Then the QRS comes. So 4:1 conduction. There are flutter waves seen. So this is an ECG of an atrial flutter. Atrial fibrillation again will have a high range, but irregular ventricular response and a narrow QRS complex. Again, adenosine response, they will have a transient AV block. Baseline fibrillatory waves will be evident with AV block. So please note, atrial fibrillation can lead on to LV dysfunction, and they may also require anticoagulation because there is a chance of what happens that atrial appendage thrombus or thromboembolism can occur. Then other things are the EAT and the PGAR. So I wanted to tell you something here is when in PGAR you may get a negative P wave deflection in lead 2, lead 3, and AVF. Okay. So that is one thing which we should be careful about. So in short, about all these things, the ideas is like there are two mechanisms. One is re-entry and another thing is automaticity. So whatever it is, how will you know? What will you do for a child when the child comes with very high heart rate? Is first is initial assessment and stabilization of airway, breathing and circulation. Once tachyarrhythmia is suspected, definitely the child should have an immediate hemodynamic assessment and a 12-lead ECG. Throughout, the ECG monitoring should be going on once you are doing any therapeutic maneuvers, because that will actually help you in providing an insight to the cause of tachycardia and help in management. So what this is the SVT algorithm adopted from APLS. So please try now, see here, vagal maneuver should be tried first, but should not cause undue delay. So what is happening? The thing is depending on whether the shock is present, the shock is absent. This is a very important diagram. I think you can take a printout of this and paste it in your clinics or the hospitals. This is freely available in the net. I request all my viewers to read through the STG guidelines. They're amazing guidelines. One more big thanks to all the authors and our president for the active for initiating this action plan. So now next is shock. So once the patient is there and the patient is realizing that we are checking out the patient, there is hemodynamic derangement, is the shock is present, then yes, if the shock is present, the first you can do a vagal maneuver if there is no delays. And if we are establishing a vascular access is quicker, means go for adenosine. If the establishment is not easy, just go for DC cardioversion with 1 joule per kg, increase it to 2 joule per kg if there is no response. In that case, even 2 joules per kg, there is no response, consider amiodarone. I hope you are clear here. Whereas the patient is coming to you and there is shock, we are checking and there is no shock, go for vagal maneuver, go for our drug, the adenosine. Adenosine is in the dose of 100 mics per kg. After 2 minutes, if the rhythm is not getting reverted, go for 200 mics per kg. Again, after 2 minutes, go for 300 mics per kg. Please consider adenosine. Even if still no response is there, you can go even up to 400 or 500 mics per kg. In infants, we generally don't go beyond 300 mics per kg. Okay, and then consider synchronized DC shock or amiodarone or other antiarrhythmics. In that point, actually, it's better we seek the advice of an expert here. The maximum dose is adenosine is 12 milligram. Units is 300 mics per kg. So how will you actually do this vagal maneuvers and other things is in neonates and infants, we can elicit the diving reflex. How what happens? That will actually increase the vagal tone and will slow the conduction of the AV node and interrupt the SVT. But main thing is you have to explain the procedure to the patient. Baby is attached to a cardiac monitor, restrained by arms wrapped in a towel, a rubber. Actually, there are two mechanisms. Either you can take a towel, just apply in this, soak it with ice cold water and apply over the face, or you can take a rubber glove filled with ice water and apply over the face. It is safe and 90% effective in terminating the tachycardia. Again, we are telling, please don't forget to explain the procedure to the parents. In case of toddlers, again, application of ice cold face cloth or a rubber glove filled with ice water can be tried. One-sided carotid massage can be performed, but do not use that ocular pressure thing in the child or infant because it may lead on to ocular damage. What we'll do in case of school children? Again, application of ice cold face cloth or rubber glove filled with ice water to the face. One-sided carotid massage, yes, but not ocular pressure in an infant child, school child, etc. But still, it is not. We are doing the vagal maneuvers. It is not getting reverted. Please consider the drug of choice. That is our adenosine. This is for the choice for narrow complex tachyarrhythmias. This acts by blocking the AV node and is both therapeutic and diagnostic. So one main thing is it's having such a short half-life. The half-life is less than 10 seconds. So whenever you are giving, you have to have a three-way, and that has to be as close to the heart as possible. So that is why we actually attach the three-way, just push the adenosine, and when we are doing that, the meanwhile the other port, we are keeping a flush ready. The moment you are pushing the adenosine, just close it, the other flush should go. Because the T-half is only less than 10 seconds. It has to reach the heart to act. Okay, so it is delivered as a rapid bolus injection to reach the coronary circulation and thereby the blood supply to the AV node. So this is what I was trying to tell you. As close to the heart as possible, preferably in the antecubital fossa, we can attach a cannula with a three-way. Adenosine can be given by rapid IV push followed by 5 ml of normal saline through the other port. The first dose is 100 mg per kg. Next dose is 200 mg per kg after 2 minutes. Again, if not reverting, you can go up to 300 mg per kg. The maximum dose is 500 mg per kg in an infant less than 1 month up to a maximum of 12 milligram. Throughout the procedure, we have to record the ECG. After giving adenosine, children may complain of transient flushing or just tightness, dyspnea, nausea, etc. There may be irritable cry in infants. The mechanism of action is, as I've already mentioned, they temporarily block the AV node. So ECG should be done by 2 because there we may see a brief period of asystole before the sinus rhythm returns. If the technique is correct and the child does not revert to sinus rhythm after the maximum dosage, we have to review the diagnosis because we may be dealing with some other tachyarrhythmias or a natural flutter and consult an expert in such a condition. What about the electrical cardioversion? If there is no response to IV adenosine, consider electrical cardioversion, or if there is an evidence of shock, you can actually, if the vascular access is difficult, just go for DC cardioversion. If the patient is conscious, we have to have an IV sedation or anesthesia before cardioversion. What is the dose you will give? You will give at 0.5 joules per kg. You can increase at 1 joule per kg or 2 joule per kg as the condition requires. What are the other drugs which can be used is, one is amiodarone. This is another drugs question. It is safest anti-arrhythmic in the post-op situation, that is amiodarone. It is useful for tachyarrhythmias which is not responding to adenosine and also to the resistant WPW circuits. Just remember this, the dose is 5 mg per kg mixed with 50 ml of 5% dextrose IV over 30 minutes. And we should watch hypotension. Another drug which is used is flecainide. This is also a membrane stabilizer, but it is little pro-arrhythmic and has negative inotropic effect. Not used for contraindicated. It is basically contraindicated in children with congenital heart disease. What are the other drugs used? The propranolol 0.1 mg per kg slow IV. This used to be used only if we have facilities for pacing, because once you give propranolol, an asystole may occur, and we should not give propranolol if already verapamil has been given, because both have negative inotropic actions. IV metoprolol and same dose can be used in case of non-availability of IV propranolol. If IV propranolol, IV metoprolol, nothing is available, you can even take oral propranolol, crush it, and put it via the nasogastric tube. The dosage is 1 mg per kg. Verapamil is absolutely contraindicated in children under 1 year of age as it is associated with profound hypotension and asystole. Dosage is 0.1 to 0.2 mg per kg to a maximum of 5 mg. The drug should be terminated when the sinus rhythm is seen, even if cochlear catheter dose has not been given. And if they have received a beta blockers, flecainide, amiodarone, etc., we should not be using a verapamil. So what is the maintenance treatment? The problem that depends upon whether the SVT is completely resolved or not. That complete resolution depends on the age of the child. What happens if it's an infant coming to you? There's high chance that the SVT may resolve. Whereas in a child, baby or diagnosed after 1 year of age, only 33% will resolve completely. So we may require a maintenance therapy. The most commonly used is a beta blockers, that is propranolol. In case of recurrent or prolonged tachycardia, the dosage is 1 mg per kg per dose 8 hourly, usually weaned off after 6 to 12 months. Oral flecainide can also be used for the control of AV re-entry tachycardia or WW syndrome. Dosage 6 to 8 mg per kg per day in 3 divided doses. And in children, that is in infants. So in children, slightly lower dose of 3 to 6 mg per kg per day in 2 divided doses. Do not use flecainide in cases of children with congenital heart disease. Digoxin, calcium channel blockers, not to be prescribed in patients with WBW prior to full cardiology evaluation. We can consider sotalol or amiodarone for the medical control, but the ultimate treatment, one thing is the radiofrequency catheter ablation. This will be the definitive therapy of SVT at low risk in patients beyond the toddler years. So these are the references. In this session, we have actually discussed what is supraventricular tachycardia. So please remember, the rate is really high. In infants, it is it is more than 220 per minute. And beyond that age, it is more than 180 per minute. It is a narrow complex QRS tachycardias. There are different mechanisms for that. So what exactly you will see in the ECG, how exactly you will manage, everything has been told. But please know the Vagal manuals. Please know the doses of amiodarone which should be used. And if it is not getting reverted with the thing, and if there is a shock present, kindly consider the DC Cardioversion. So there are so many things which are actually discussed. These are the references given in the IAP SVT guidelines by the authors. I hope the session was clear. There may be lots of doubts. Please go through the manual, and thank you and take care.